from Bukit Batok Green Ribbon Task Force, and I will be the moderator for today's session. Our task force, just a reminder, hopes to raise awareness about mental health wellness, especially during this very stressful season for everybody. Today, we are privileged to have Dr. Irene Chertayana, who is the head and senior consultant of the Department of Psychiatry. She will be sharing on the topic of anxiety and depression, which are the most common mental health conditions faced by Singaporeans today. Her sharing today will cover an overview of the conditions, possible treatments, some self-care, and preventative care tips. There will be a time for question and answer after Dr. Any questions that you have along the way, feel free to key it into the chat box at the bottom of your Zoom screen, and we will address your questions after the sharing. I'll now pass the time over to Dr. Irene. Dr. Irene, please.
Okay. Hi. Thanks for the introduction, Linus, and thank you for the invitation to this mental health and wellness talk. Okay, so this is a very common topic when it comes to anxiety, depression, the community. It's actually anxiety and depression, we can say, is almost like the bread and butter of psychiatry. And why it is important for community mental health is that these are the kind of things that happen more commonly, right? So because it's so common, we do think in the mental health field, we do think that it is beneficial for everyone, and more people to actually know about these topics. Okay, now this one is from a presentation by the COVID-19 Mental Wellness Task Force Report 2021, right? So it's very recent and it really reflects the kind of challenges faced on the mental health front during the pandemic. It is also important to remember that although the pandemic is largely under control and is over, we are facing the part what last time was called the long tail of COVID. Okay? So the COVID itself, the pandemic itself, the disease, active disease and infections and all that, maybe we do know that there can be waves of it in the future, right? With different types of COVID virus coming up, right? Types. Okay, but this one, the mental health side, on the mental health front, we do know that it is going to continue to affect people for a long time. So the impact is going to be years probably. Okay. So this study was done in 2020. It's a quick survey of a few hundred people in Singapore. Right? Surprisingly, it is actually a lot of people actually registered pretty high on the level of clinical depression and clinical anxiety and severe stress. Okay? I would be very interested, repeated perhaps in the next year or so. That would be very useful to find out how people are coping after the COVID pandemic is over, right? Okay. How? Actually, not too bad. Yeah, not too bad. You can see the UK figures are much higher. China figures are high, right? Japan and all that. So if you look at the figures, actually Singapore did not, but all things considered, it's not too bad. Okay. So that's what's been happening. Yeah, but what else does this COVID pandemic actually bring forward, right? It's actually the recognition, the awareness, the understanding about how mental health affect all of us. Okay. To be fair, even before COVID, there have already been task forces on mental health issues nationwide. There are already been mental health blueprint from like 2012, if I'm not mistaken. Right? So the focus is already there, but it's expected to be like an ongoing work. Now with COVID-19, what happens is that everyone is just forced to work faster on this, yeah, because the impact is just so large. Okay, so okay, this one just some slides that I put in on how depression and anxiety can also affect medical conditions. Okay? And why this is important is because after COVID-19, we also expect that people might be coping a lot more with these chronic illnesses. Again, already there from before, but the pandemic actually brings forward the acute necessity of how we manage these kind of conditions. Yeah. This one, they specifically mention things like diabetes, which is very common in Singapore, for the middle age and heart disease, and a lot of other chronic conditions. Okay. Okay, so when it comes to anxiety and depression, usually I start with this slide. The difference between fear and anxiety. This is important to know also because on some level, I think it's still not very clear for a lot of people what is considered normal and what is not normal. Okay? So what I want to emphasize here is that fear is a normal emotion. All right, so fear is a normal emotion. It is necessary for survival. If you don't have fear, you'll get burned by fire, we'll fall down, fall off buildings, that kind of thing. Because it's just there is no sense of what not to do, right? So fear actually is important for survival. We do know that, yeah. So that is actually an unpleasant emotion. It can be sensed in the body, feeling the heart is beating fast. But what's the difference between fear and anxiety is that fear comes up to as a reaction, as an emotional reaction to something that is present. Okay, now something that's present either externally or internally, right? An example is this: if you walk down the street and then you see a lion, right, a hungry lion, roaring at you, it's normal to feel afraid. Yeah, so it's just a very normal reaction. It's not pathological in psychiatric terms. We don't call it pathological. So it's not a disease, right? It's not a symptom of a disease. It's just a normal reaction. It gets a little bit more complicated when it comes to anxiety, right? Because anxiety actually is mostly the symptoms can be quite similar to fear, yeah, but it can be more long-standing. It just lingers on in the background. So instead of a spike of emotions, it can just be brewing on in the background for a long, long time. It can be hours, can be days, can be weeks or months, right? And what is happening with anxiety is that it is more often a reaction to a thought process. Yeah, so it's almost always internal, a reaction to something internal. An example is this. Again, very common, right? Expecting that your boss will scold you, right? Or expecting that you be criticized by your colleagues or friends or family. So it may not actually be happening, all right? But the expectation of it, expectation of some future occurrence, and which is planted in the mind and doesn't go away, basically, right? So there is something in the mind, usually a thought process, a belief, a prediction that is fueling that anxiety. So it keeps firing off over time, little bit, but so and this one is just a summary of that. Now, both fear and anxiety have a lot of similarities when it comes to physical symptoms. Okay? Usually, it is more toned down in anxiety, not as strong or as acute as what comes up in fear, right? But it's more or less around the same ballpark. So things like muscle tension, breathing difficulties, feeling that the heartbeat is fast or irregular, right? And sometimes there can be things like stomach problems. You need to go to the toilet or feel like vomiting. Okay, so all this also can happen in fear reaction. Also happens in anxiety reaction. So now, because anxiety tends to be more long-lasting than fear, it does affect the body slightly differently as well. So if the muscle continues to be tense, then people often get things like headaches, shoulder aches, neck aches, that kind of thing. So these are the kind of tension that comes up from prolonged muscle contraction. Yeah. So think about the people who work at the computer like that, right? Sometimes it can be habitual, might not always be because of anxiety, but a lot of the times there is some anxiety there. Yeah, the posture sometimes tells you as whether the person is anxious or tend to be anxious. So anxiety, unlike fear, can be habitual. It's like a mental habit. Yeah, it just stays there for a long time. Okay, so there can be things like sleep problems, feeling fatigue, concentration problems. Yes, also all this can happen. Yeah. Now, okay, so this one is just a recap of a lot of the physical symptoms of anxiety. Sometimes people lose appetite. People can have feeling like they want to go to the toilet all the time. Repeatedly, that can be because of anxiety as well. Well, I mean, sometimes it's really urine infection, right? But can also be anxiety. Dry mouth. Okay, so many physical sensations can be due to anxiety, right? And are they all pathological? That means if let's say you go home and then you realize that, hey, my mouth is a bit dry, and then sometimes I go to the toilet more frequently, do I need to straight away go and see a doctor? Yeah. Now that comes with the territory on how much the symptoms are bothering you. Okay, so psychiatry is simple in that sense. Yeah, how much of the symptoms are bothering you? Okay, so to give an example, in the more worst kind of cases, right? People might be unable to do anything else. They can spend the whole day just worrying, right? Or, for example, in people with panic attacks, sometimes what happens is that they become afraid to leave the house because they think they might get a panic attack outside. Yeah? So that is an example of how anxiety symptoms can uh, cause a lot of problems in life. In social anxiety, school children sometimes, or even teenagers or young adults, sometimes will refuse to go to school or refuse to go to work because they feel anxious. That's the impact component. So for anxiety, apart from the emotional component, there are thought processes that can happen also. Sometimes, this one I hear quite often. During exam, cannot think. Or want to sleep but too many thoughts. Yeah, so that's an example of how thought process with anxiety can affect a person. Okay, physical, we talk a lot about it. Now, I want to just emphasize, because this one is a common question and it's a common issue. When it comes to physical things, right, that arises out of anxiety, and a lot of people didn't recognize it. Yeah? A lot of people don't know this because of anxiety. So they think, oh no, am I having a heart attack? Am I having a heart problem? Am I having stroke, right? Feeling dizzy, sometimes headaches or this and that. Okay, so once it is checked by a doctor, right? And usually they go through some investigations, and then the doctor tell them, okay, this one is not heart attack, this one is not a stroke, right? And then of course the person is left like, but what is it? What is it, doctor, right? Because I do feel uncomfortable. I do have all these symptoms. Yeah? Now, some doctors would sometimes straight away refer you to see a psychiatrist, right? Or ask you if you want to go and see a psychiatrist. And that's fine. I think that's not a bad idea. Sometimes it's helpful to actually get it properly diagnosed, to at least reassure the person that, yeah, these are anxiety symptoms. Yeah? Of course, some people refuse to do that, and if they don't feel too bad and they can accept that these are not actual medical conditions, that means it's not like something is wrong in the body, right? And they can accept that this is from anxiety, and they can manage it themselves. Yeah, that means keep going to work, keep going to school, and all these things. That's also fine. Yeah, that's also fine. Yeah. So in essence, because these are such common conditions, it is useful for people at all levels of society to actually understand this. Now, the current batch of school children are very lucky, right? So they learn more about mental health and emotions and all these things in school. So these are actually taught in school nowadays, and they are school counselors as well, right? So they are school counselors, and last time, I mean, they are school counselors, but usually the pickup rate is not that high, and then. But even up till today, it's still quite common as well for school kids not wanting to see the school counselor. So that's a perennial problem, right? So yeah. Okay. Okay. So when does it become pathology? When does it become illness? Yeah. So it becomes an illness when it affects your functioning, right? Of course, the impact can be mild, moderate, or severe. So in that sense, we can stratify, we can divide the condition into mild, moderate, or severe based on the impact on life. Okay. Now, danger. All right. Yeah. So that's mostly based on the functioning side. Although I have to say, sometimes what happens is that the person with the condition themselves might downplay it. That means they um, refuse to accept how severely it is affecting them, right? So this we still see quite a lot of the time. Usually it's the family members who are more worried about the other person. Okay, so that one goes way into the family dynamic side and all that. And usually the counselor or family therapist can help with that, right? Okay, there are different types of anxiety disorders, and these are not everything, right? So I just pick a few. And the ones that got a star here, actually now are no longer classified under anxiety disorders, but under other types of disorders, right? So like post-traumatic stress disorder, now is put into the trauma-related disorders, obsessive compulsive disorder. Now it's got its own segment, right? But I still put it here because they're somewhat related. Okay, very common one, very, very common condition. Yeah, so panic disorder, okay, when it becomes a disorder, when it's called panic disorder, usually it means that there are repeated attacks, and the person is highly affected by the anxiety attacks, right? However, if someone only has one panic attack is, by the way, very, very common. Think I remember seeing somewhere some studies or in my textbook that says that like in your whole life, your chance of getting a panic attack is 50%. One in two, right? So if you ask people around the age of 60, 70 years old, whether they have had one panic attack in their lives, then half of them will say yes. So it's extremely common. And it doesn't mean that if you just have one panic attack and nothing else, just one attack, it's okay afterwards. That you need to see a psychiatrist, right? So it's not like a must. So what happens, however, in panic disorder is when the panic attacks come up again and again, right? And the person develops a lot of fear or avoidance or anxiety in between attacks. So now the impact is much, much bigger. It's no longer just a one single attack. It's over, never happens again. But it's one attack here, then another few days, another one, or some people even have it several times a day, which can be quite disturbing, quite disruptive to life. I mean, imagine you are in a classroom and then you get a panic attack, or you're working, you get a panic attack, or you're driving, then you get a panic attack, right? Now, every time the panic attack happens, the person can experience several of these things. It's not just one, it's several things at the same time. Heartbeat fast, cannot breathe, chest tight, feeling like nauseous, feeling dizzy, shaky, sweating, right? So it all happens at the same time. It's very scary for a person, very, very uncomfortable, very scary. And a lot will have the thought that I'm going to die, I'm going to collapse, I'm going to die, or I have a heart attack. And a lot of people with panic attacks end up in A&E. End up in A&E because they didn't know it is actually a panic attack and it's not physically dangerous, right? So it's not physically dangerous. But for most wouldn't be able to tell apart, whether it is a panic attack or something else. So they end up in A&E. Then, of course, in A&E, the doctors will do the necessary investigations, take blood, do the heart tracing, chest X-ray, right? And then conclude that this is not a heart attack, right? So, sometimes the patient might still be referred to a cardiologist anyway, just to be safe, referred to a cardiologist who then examine the heart in a more thorough manner, through the echo, the CT, angiogram, that kind of thing. And then, when everything is all done and the heart is actually fine, there is actually no heart condition, no heart disease, but the panic attacks still happen. If that's the case, panic attacks still happening, the person is still very afraid of it, and it is affecting life in many different ways. A lot of people with panic attacks start avoiding going out or avoiding social activities for various reasons. Because they feel if they go out, they get a panic attack outside, it's very inconvenient, right? Or embarrassing. So there are a lot of this kind of beliefs, right? And then people start avoiding social activities and all that. They stay home more often. Some would actually avoid exercise because they feel the exercise itself reminds them of a panic attack. Because when people exercise, your heartbeat goes faster, right? And that reminds them of a panic attack. So they don't like the feeling. So it does impact people in different ways. And they might get to see a psychiatrist and get treated. Do people with panic disorder always have to see a psychiatrist? Again, no. Right? Of course, if you're not sure whether this is the case or not, please see, right? See a psychiatrist. But in the very mild end, if the person is getting some kind of counseling, or they start to understand that this is what's happening, they can self-manage the condition. It may not even be necessary to see a psychiatrist. Or maybe you get to see a GP or a polyclinic doctors. So now in the polyclinics, they have this thing called the Health and Mind Clinic, right? Where people can see the milder types of psychiatric condition. And that's perfectly fine as well. So there are different options now in terms of treatment. Okay, now agoraphobia is a kind of phobia. There are different types of phobia, right? Phobia is like a very, very strong fear or something. And lots of people have phobias. Okay, I can think of, I don't know, maybe 10 people I know who's scared of either a cockroach or scared of a lizard. Scared of cicak, right? The house lizard. So those are very, very common. Okay? And generally, as long as it doesn't affect their life so much, right? Most people do not see a psychiatrist for this, right? Lots and lots of people have fear of needles or injections or blood, So generally, it is not affecting them too much. People don't see anyone for it. Yeah? So that's when it comes to phobias. But when it comes to panic attack and phobias, some actually develop a very, very strong fear as a result of the panic attacks. It can develop a very strong fear of open spaces. It's not quite open spaces. Although the word agora actually means market, right? So it's literally it's a fear of the marketplace, but it doesn't really mean that. It means usually a wide open or enclosed space also can, where there can be a lot of people, it can be crowded, and it is difficult to actually escape from. It's difficult to retreat from the stations, actual markets, supermarket, bus station, terminals. Can be anything. So it's usually a place outside the house where it is difficult to come back to safety. And often it is connected to the panic attacks. So the person might, for example, have the first panic attack in this place, and therefore they start to develop the fear or the belief that these places are dangerous or potentially dangerous, right? And then they start avoiding going to these places. Now, in severe cases, a person with panic attacks and agoraphobia or just agoraphobia can literally just stay home and never goes out at all for years. Yeah, we have cases like that, right? People just don't go out of the home because they are afraid to go out, right? So that's the thing. Okay, so let's see. Okay, another one. So there are different types of anxiety disorders. Yeah, this is another common one. Social anxiety. So usually related to social situations, eating in public, speaking in public, talking to strangers, talking in class, asking a question in class, any kind of performance, right? Yeah, can be in front of familiar people or in front of strangers. Yeah, so, the fear actually stems from when it is explored. No? When it is explored, it stems from the fear of being judged by others, right? Being negatively judged by others. Fear of potential of being embarrassed or humiliated, right? So often related to low self-esteem, poor social skills, or extreme shyness. There are physical symptoms associated with that. So some would be common one, heart beating fast, yeah, happens everywhere, right? Any kind of anxiety disorder can have this symptom of the heart beating fast because it's just a physical reaction to a perceived threat. Yeah? Stammering, but the speaking process can be affected in this kind of scenarios. Stammering or blushing or shakiness. Yeah? So these are some of the symptoms of social anxiety disorder. Now, again, same thing with the panic disorder just now. How much of it is uh, affecting your life, right? So a lot of people have this, you know, it's not uncommon. It's like, I mean, I used to have it when I was a teenager, right? So it's very, very common, you know, stammering, blushing, feeling shaky and all that. In fact, if you ask around among family members or colleagues, if they are honest, if they tell you the truth, I think I suspect about 30 to 50% will tell you they might have it. Yeah? Depending on your age, depending on your age. But this will be more common in the younger age group. Why? Because over time, as people get older, it can get better by itself if they don't run away from it. Okay, so if they don't completely avoid doing it, so they keep doing it a little bit at a time, it gets better. Right? So it's just one of those things. Yeah. But I do recognize for some it is extremely, extremely difficult and even impossible. Yeah? And again, same thing like the panic disorder. Some people can't even leave the house. It's that severe until they cannot leave the house, right? Or they cannot go to school at all, or cannot go to work at all. So that level of severity. A lot of people are in between. Right? It's not so mild that they can just ignore it. Okay, and they do feel like it's affecting their career prospects or it's affecting their studies in some ways, right? So that's kind of like a moderate impact. Okay, let's see. Okay, this one is interesting and it's we call that generalized anxiety disorder, yeah, GAD. A little bit hard to explain. In a sense, the worry is about nothing specific, right? Now, remember when it comes to things like panic disorder, the worry is about, am I going to have a panic attack again? All right, or is this symptoms, the feelings I'm getting, the panic attack symptoms I'm getting, is it actually a heart attack or something more dangerous, right? So those are the typical kind of thought or worries that comes up with panic disorder. When it comes to social anxiety disorder, the thoughts are about, are people going to judge me? Am I going to embarrass myself, right? Or am I going to blush or stammer and make things worse for myself? Right? So those are the typical thoughts of social anxiety disorder. When it comes to generalized anxiety disorder, it's nothing specific. It can be anything on earth. It can be anything. So the worry is about could, it's like the topic can change day by day, week by week, right? This week worry about COVID, next week worry about finances, the next week worry about a family member, next week worry about something else, right? About health or whatever, right? So it can be anything. Yeah. Sometimes people with this condition can even worry about worrying too much. So ironic, no matter ironic how that sounds, that's what happens, right? So worry about getting worried. Now, so basically, it's a very long-standing anxiety about everything. So you can imagine, usually people affected with this condition often feel a lot of muscle tension, very long-standing, right? Get headaches, stomach problems, fatigue, often get insomnia, problems sleeping, and difficulty with concentration. So these things are, again, not uncommon. I think Singapore probably about 1% lifetime prevalence. Okay, so it's long-standing, it's very varied. The worries itself can change. The only thing that's in common is just the feelings of anxiety. Okay. So that's what we call free-floating anxiety. Okay. And often very worried about the medicine as well. when we recommend treatment through medication, usually very, very anxious. Okay, well, okay. I think the color, the color plan actually changed when I changed the background, so it looks so colorful now. All right. So this is old paper from 1993, but I thought it illustrates quite well how anxiety develops, right? So, okay, now every day, every moment, yeah, not just every day, every moment, flooded with information from our surroundings, both external and internal. Okay, so examples of external things would be sounds in your surroundings, all the objects that you can see that's within your field of vision, right? All the sensations that you can sense, right? Smell, taste, right? So all those are external and internal. So there are also many of internal stimuli that we actually filter out. We filter out a lot of these things, right? So most people on a normal basis, they are not aware of sensations of their heartbeat, for example, right? So on a normal basis, people are not aware of that. It's just filtered out, right? Most people are not aware of their breath sensations. When they breathe, yeah, we know that there are sensations we can feel, right? When you breathe in and out. But most people are not aware of that, unless they specifically pay attention to it. Okay? So all these are naturally filtered out. Most people are not aware of sensations on their feet when they stand, right? Or when they sit down, sensations on the backside or on the back, when you lean on the seat. Not aware. Sensations coming from your clothes resting against your skin, right? People are not aware of it. Yeah. So what I'm saying is that there are hundreds, literally hundreds of things that are being sensed every moment, right? And all these are just filtered out automatically. Okay. Now, some of these stimuli, the internal ones, include your own thoughts, actually. And like all the other things, they just filter out. Most people are not aware of what they are thinking, right? So, it is just an estimate. It's just an estimate that people have, like, I don't know, something to the tune of a few dozen thousands of thoughts a day. Okay, so many thousands of thoughts a day, right? But if you ask people, cannot remember, cannot identify, cannot remember. All these are just filtered out. Okay, so that's thanks to something that we call, just a term. It's just a detector. There's like a filtering system. Yeah, so that's detecting it and filter it, and then only a few comes up to another system where it evaluates the significance of this information, right? And only one, there can only be one, eventually when people start to get panicky or start to be very fearful or anxious about something, there can only be one usually at a time, one at a time, right? This conscious perception of threat. So that comes up front and center into your awareness, your, being evaluated by the whole system as being threatening. Yeah, and then that's when the fear, sensations, and everything else comes up. And can manifest either as fear or anxiety, right? Depending on how acute it is or what kind of things it is. Okay, what are these two here? Arousal system, expectancy system. Now in psychology, psychiatry, we talk a lot about arousal system when we talk about anxiety. Yeah? So the arousal system actually is the part of your brain, nervous system, your body that actually puts you on alert mode. Okay, so this is the kind of system that makes your heartbeat goes faster, make your muscle tense up, make your mind goes into hyperdrive, right? That sort of thing. Make you more awake as well. Nobody feels sleepy when they are actually having a panic attack. Yeah? The reverse of that is when people are feeling tired, feeling sleepy, basically. Not alert. Not alert. So that's what we call hypoarousal. So it can go into a heightened arousal or lower arousal. Right? And largely this depends on the hormone that we call adrenaline. Yeah, so there's a hormone that's produced in the body in response to perceived threat, right? So this perceived threat. And why is there a line here? Because when the body is aroused, that means the body is on alert, right? The body is on, the system is on alert. It will actually detect more things. Yeah, it will actually detect more things and perceive more things as being a threat. Yeah, so there is actually a positive feedback. The more anxious you are, the more anxiety-inducing things you might notice. Right? So, okay, what else? Expectancy system. All right, this is interesting, and I might talk a bit about it later if I have time. This has to do with your belief system. It's your belief system, basically, right? So that means, and all of us have beliefs, right? I'm not talking about religious beliefs and all that, but beliefs about what life is about, beliefs about how threatening certain things are, beliefs about other people, that kind of thing. And a lot of these are quite subconscious. A lot of people are not aware of it. Yeah, it's just deeply embedded in the system. Something that's just absorbed or picked up from people around from the time when you are very, very young, right? Including the time when you are still a baby, right? So all this often doesn't even come up to consciousness. Yeah, it just affects your behavior. Okay, so this expectancy system contributes to what you think is threatening or what you think is significant, right? So from the many, many, many stimuli here, how your brain, and all this is automatic process, is behind the scene one, right? In the end, you select a few to be deemed significant and you select one to be deemed as a threat. Is based on this expectancy system. All right. Yeah. So maybe we talk more about child or upbringing and all these things, all those things. Okay. Let's see. Okay. So I saw a question about depression earlier. So we talk. This is the part where we talk about depression. Depression is probably the most common mental health condition that people are aware of, right? From the psychiatry side, sometimes what we notice is that anything also is called depression, right? So sometimes when people have seen other doctors or other psychiatrists, then you have to ask, what were you seeing this doctor for? The answer is almost always depression, no matter what they actually are seeing them for, right? So this is just a very common one. When we come to a formal, an official kind of diagnosis, the term is major depression or major depressive disorder. and they actually have very strict criteria for this. This is based on DSM-5. The UK side use a slightly different system, but it's quite similar. Right? But the idea is that we are not talking about normal sadness that comes and goes and all that. Yeah, we are also not talking about grief, because grief is another reason, losing a loved one, right? Losing a loved one is another reason why people can feel quite down and sad for long, for long periods of time. But that's not it. That's not it, right? So for major depression, the low mood has got to be quite significant, yeah, and has got to be there most of the time for an entire 2 weeks or more. Usually, by the time people come and see us, it's a few months already. If untreated, if it is untreated, it can just linger around for months and months and months. Some people are lucky enough, and after maybe 9 months, 10 months, 1 year, they just got better by themselves, right? So it is possible to get better by themselves, but don't count on it, yeah? Doesn't always. Okay, so depressed mood, loss of interest in activities, or no longer feeling normally pleasurable things as pleasant. So, for example, some people enjoy to go out and hunt for good food, right? Yeah, like go to different places around Singapore, try to get the nice hawker food and all that, right? And they just stop doing that, for example. Yeah, so that's just not interested anymore. Or some people maybe enjoy playing computer games or enjoy watching K-drama, and they're just no longer interested. And not for a reason because the interest has shifted. That means they are interested in something else. No, it's just not doing anything. Yeah, not interested in anything. Okay. Quite often, some would actually have weight loss or weight gain, right? So that means the appetite can lose appetite, or can actually have a lot more what people call comfort eating. Yeah, so that's possible. Feeling fatigue a lot of the time, problem with falling asleep or staying asleep, insomnia, or the opposite. Yeah, so these two can be opposite ones. Both also can, right? Um, and this is so these are more physical stuff. Yeah, these are more physical stuff. This is more emotional stuff. This one are more of the thinking processes. Yeah, so thinking process, there are a lot more feelings of worthlessness or guilt, inappropriate, yeah, inappropriate guilt, right? So now the feelings of worthlessness was not there before. Yeah, so normally the person can tell you they don't feel like this. Um some cannot tell the difference. Yeah, but I mean, unfortunately there are people who from the time they are very, very young, maybe because of upbringing or something, they often feel worthless. Right? So from the time they're very young. So they cannot tell us that last time I didn't feel like this, now I feel like this. Because they've always felt like this, but now it's worse, right? So it can be like that. Problem concentrating, yeah, or cannot decide things. And suicidal thoughts, of course. Now this is the part that can really worry someone. Either the person themselves, because they don't want to hurt their loved ones, right? So that's the interesting part, even for people who are depressed, right? People who are depressed and having suicidal ideas, a lot actually don't want to do it. Okay, so they do not want to actually kill themselves. Yeah, right. In fact, the suicidal thoughts actually make them feel worse. Make them feel worse because they started having more thoughts about how could I even think of this, right? How could I even think of killing myself and hurting my loved ones? So that actually makes them feel even worse and make them feel even more worthless, right? Make them feel even more guilty, right? So it's like a vicious cycle, basically. Now, the suicidal ideas also, and I need to mention this also. Having suicidal ideas, although we do take it seriously, we do take it seriously, but it does not mean they will actually do it. Okay, so this is what I always tell my patients, colleagues, students, right? From the thought to actually doing it, there are many, many steps, right? So what we are picking up also is how close they are to actually doing it. Okay, and yeah, there are certain things that psychiatrists will ask. Not, might not be relevant. Okay. Okay, so other psychological symptoms of anxiety, a lot. Yeah, I mentioned quite a few already, but anxiety is one of it as well. Yeah. In fact, anxiety and depression tend to coexist, or it can coexist a lot of times. Hopelessness, reduced self-esteem, rumination. What is rumination? It is actually the kind of a special kind of thinking process where a person just keep thinking about something and something and never let go of it, even when they are aware that it is not helpful to continue thinking about it, even when the thoughts hurt them, actually feel bad to them, but the mind just cannot let go of it. So, and hypersensitivity to rejection, right? So that's the one that we. So. Okay, what about physical symptoms? Quite a lot. Yeah, so I think this side I talked about already. This side, a lot more chronic pains and aches, and some are quite similar to anxiety symptoms. Uh, yeah. Now, we also know that for some people who are not very good at expressing themselves emotionally, right, recognizing their emotions and verbalizing it, right? Some people are not very good at it, and this is probably more common in the older generations. Sometimes it comes out with a lot of this kind of physical symptoms when they're depressed. Okay? Yeah. Okay. So, okay. I think in the interest of time, I will not be able to cover everything, but okay. This thymic disorder basically is a kind of depressive disorder. But instead of like major depression, right, which is like very severe, quite severe lah. They are mild ones also, right? But we still call them major depression. Um, this thymic disorder is more long lasting. Yeah, so it has got to be more than 2 years. So it's quite long lasting. For major depression, if you recall, it was only 2 weeks. Only need 2 weeks, then can diagnose already, right? But a lot more symptoms. A lot more symptoms. For dysthymic disorder, it can be 2 years or more. Yeah? And don't need much actually, just a few of this thing can already. Yeah, so the classification is just like that, right? So classification is just like that. Okay. Okay, why I put adjustment disorder here? Because in a sense, COVID actually brings a lot of this. Yeah, of course, COVID also brings a lot of major depression, anxiety disorder, all the other things talked about earlier. But adjustment disorder is what say when there are symptoms, new stuff, yeah, new unpleasant symptoms that are being noticed, right? But when there is a clear stressor, so the person can tell you because of this thing, I started feeling like that, right? Started cannot sleep cannot concentrate mood quite bad so many different things like that, and a lot can overlap with depression, except that if it is severe enough, call it a depression, then we call that depression. If it is not as bad as depression, and clearly it is connected to some new stress, then we call that adjustment disorder. So that's this is really like the cough and cold of psychiatry. It's like I think everyone would probably have this once in their lives after this, after COVID especially, right? So yeah, it doesn't actually how to say when the stress is removed, usually they feel better, right? So that's a pattern that is common in just and might not even need any special treatment or anything in that sense. A lot don't need to take medication unless it's going to be long term. Right? So people can feel anxious, can feel depressed, can have both. And in children, they can have conduct problem or emotional disturbances. Okay, talk a bit about PTSD, right? Okay, this one, I think I made this slide many years ago. It is no longer considered anxiety disorder. So it's got its own separate section now. But basically, now, an interesting trend that we see nowadays is that the term trauma is kind of like being bandied about. So a lot of the young people sometimes just say I got trauma, right? Which is fine, I mean, no problem with that. But we have to be clear that when it comes to a clinical diagnosis, the trauma here has to be of the kind of severity where it is actually life-threatening, yeah, or extremely distressing. Yeah, so we are talking about serious accidents. We are talking about serious assaults, right? Yeah, so that's the kind of threat we're talking about lah. And the symptoms would include a lot of things, but typically it has to include several different types, several different symptoms from different categories. And what makes it different from like just anxiety or just depression is that there is this thing called unwanted recollection. Okay, so the person keep recalling that trauma, even if they don't want to, it keeps coming up. Right? Also, there is a strong avoidance about it. So it's a bit contradictory in a sense. They don't want to think about it, but the thoughts keep coming up anyway. All right, and sometimes it comes up even in dreams, so like nightmares about the trauma, So it's really unwanted. Um, they don't want to talk about it. They don't want to recall that. They don't want to think about it. They want to read news about it. But it's, so that's what you can see in PTSD. And it's got to be quite long, last more than a month after the incident, the symptoms. Okay. Now, OCD, also another common condition. It is, Singapore is the world's, hold the record as the second highest, got the world's second highest prevalence in OCD. If I'm not mistaken, it's about 3.6% or something like that. Yeah. The first one is New Zealand for whatever reason. So Singapore is the second one, right? I don't know if it's been updated after that. This was a few years back. So OCD is, I think a lot of people know about this, or at least can recognize it. Yeah? So it's a lot of repetitive things that's going on. So most people only know the hand washing type. Yeah, keep washing hands, or very scared about cleanliness, very scared of germs. But there is also the obsessional component, which is internal, so the thinking process. And some people don't actually carry out the acts, but spend a lot of time just thinking and thinking and thinking, not thinking. Not in the sense like how people who are anxious do it, but in a sense that they themselves do not want to think about it, but the thought keeps on. Alright. Yeah, so what we do know is that there are a lot of overlap. Yeah, so various anxiety disorders can coexist, right? And then anxiety and depression can and often coexist as well. Okay? Now, now this is both good and bad, right? So sometimes people react like, oh no, so you mean I have three different conditions? Two types of anxiety disorder and one type of depression. But the treatment is the same, right? So it's not like you treat them separately and then your treatment becomes three times as complicated. It's not like that. Yeah? Because usually what happens is that there is a common mechanism, either internal, external, or whatever, right? Or a combination of both, that produce these conditions, right? So and if you can address that, then so on the flip side, even if someone might have several different types of anxiety disorders, it can be treated the same way. Yeah? So okay, so all right, I think what is important here also is to not just look at the so-called negative side, the actually having a psychiatric condition, but how every one of us can do something about it. Yeah, so every one of us can actually do things in a way that contribute or support our own mental health. And that is very, very, very important these days, especially thanks to COVID, right? So everyone just, it becomes like another type of exercise here. Yeah, so now, last time, I mean, everyone knows don't smoke, don't drink, or don't drink too much. Sleep and diet are important. Exercise is important, right? So now it's mental health. Now, fortunately, the kind of things that's already mentioned earlier, the sleep, diet, exercise, also will help your mental health. Yeah, so these are really the common mechanisms of self-care. Right? Although it is tempting sometimes to separate, oh, this one is a medical problem, this one is a psychiatric problem, But in essence, if we go down to prevention, a lot of them actually have a lot of overlap. Yeah, a lot of overlap there. Yeah. So all these things can and will also improve your physical health, in other words. Okay, so it's like that very basic stuff, very, very basic stuff. Okay, now on the medical or psychiatric side, we often talk about biopsychosocial. And so this is how we formulate a condition, psychiatric condition. So on the biological side, we look at things like influence of genetics, medical problems, medication, substance abuse, right? So these are biological stuff. Some of it can be changed, some cannot, right? I mean, a very simple example is this. I mean, when people see genetic there, a lot of people will think, oh no, if my father got anxiety, am I going to develop anxiety, right? But it's not even that. It's not even that. Something even more general than that. If you're female, okay, if you're female, your risks of anxiety or depression are going to be higher. That's just how it is. I'm sorry, but that's just how it is, right? So simple stuff like that. Yeah, and some of it cannot change, right? Yeah. So but we can manage it. Yeah? So whatever it is, there are ways where a person can help themselves. Okay? So then psychological side, coping styles, belief system, personality, attachment stuff. And some of it also very hard to change. Yeah? It's not like the person is responsible for their thinking process. No, of course not. Yeah, if you remember a few slides ago, I was talking about what was it? How a lot of the processes happen behind the screen, your belief system and all that. Yeah? What your brain decides, what your mind decides is threatening or not. All this happens behind the screen. Yeah, and a lot of it is because of certain underlying beliefs that the person themselves may not be aware of. Okay, so on the psychological side, again, it's like that. Yeah, like upbringing, how you were nurtured when you were a baby, that kind of, right? So but does it mean, oh, like that, hopeless lah, and then cannot do anything? Also not true, right? So if you are an adult now and you are capable of thinking, even as a teenager, right, able to think and do things for yourself, there are always things you can do to help your own mental health. So social, yeah, a lot of things, many things here also. These are just some few common examples. Social support, finances, or safety issues. Okay, sorry, just checking the time. All right, almost done. So in terms of treatment, first, if it is needed, then you want to see a psychiatrist perhaps, or a GP who specializes in mental health to get a proper diagnosis. Treatment-wise, generally comes in two broad categories: biological, which is mostly medicine and stuff like that, and psychological, which is therapy. And then across all that, the social front, of course, needs to be looked at. Yeah, so social support, stuff like that. Okay. Yeah, and this one I took from the task force report as well. These are some of the things that the government is looking at into as a targeted preventive measures for different groups of people in population. Okay, right. So I'd like to show this slide. And last time the triangle is the normal way up. I decided to turn it upside down now because specialist care really is for cases that are already, hopefully, in future, after all these things that we've gone through. So self-care always is the most important one. We need to improve that most, in essence. Then community care, things like counseling, whether in a family service center or in school or in religious centers, right? So these two come first. And then primary health, so from primary physicians, GPs, polyclinic, and only if cannot, then or only if it is very severe that it is not applicable to be cared for in this the first 3 rounds, right? Okay, so moving forward, I think we need to recognize the good stuff, right? Nowadays, there are better utilization of mental health resources, better awareness of mental health issues, especially among young people, right? And a lot more stakeholders jumping on board. But still work in progress, stigma still extremely common. I keep hearing this again and again and again. Yeah. Oh no, am I going to lose my job? If I apply for a job later, am I going to get screened out? Right? Then later, how to apply for insurance? Right? So a lot of stigma is still present. And then sadly, this one sadly, even within the family, we still hear that a lot. My parents call me, you're crazy, that kind of thing. Yeah. So family stigmatize each other. They actually put each other down within the family, about mental health issues, and that's very damaging. That's extremely damaging, right? Because the people closest to us are the ones that can hurt us most, right? So unfortunately, it happens. So self also, there is a lot self stigma. That means the person themselves find it very difficult to accept or to move forward once they get a psychiatric condition. Yeah, but what I want to emphasize is that a lot of these conditions are very curable. Okay, so they are they are very curable. People do get better. People do get cured completely for a lot of these conditions, right? Maybe got 3-4% left. Okay, but you can lead a normal life and all that. That's, I think, to me, that's a cure, right? Okay. Self-care, although people keep saying that, but in practice it's still pretty bad lah. Myself included. Never get enough sleep and all that. So okay. Then collaboration and engagement. So with a lot more stakeholders on board, we also need better collaboration and engagement. Yeah, and this is unfortunately not happening so much yet, right? Okay, so that's all for now. Hotlines and online resources are here, right? And stop sharing in a bit. Okay, back to you, Linus.
All right. Thank you so much, Dr. Irene, for the very informative and useful and relatable sharing. I think you shared a lot of very, very good information that's useful for all of us here. Moving on to our next section, where we are very honored to have the advisor for Bukit Batok constituency, Mr. Murali Pillay, to close off the series of webinars and public mental health awareness talks for the year. Mr. Murali, please.
Thank you, Linus. I hope you can hear me. Is it loud and clear? Okay, great. Thank you to Linus, Fred, and the Green Ribbon Task Force team for inviting me. I was listening very attentively to the speech made by Dr. Irene Titajana, and I want to start off by thanking her for spending her Saturday afternoon with us, explaining the what exactly is depression and the other psychiatric disorders that we from time to time come across through our interactions with members of the Bukit Batok community. I think now we are better equipped with the knowledge and what should be the interventions that can be suggested to them, to their family members. I think we also, my sincere thanks to her as well as Fong General Hospital. Now, I've been invited to attend this closing. As some of you may know, we started this webinar series, I think in the beginning of this year. And it's really aimed at, creating more awareness. Dr. Titajana had spoken about the pyramid, the inverted pyramid, self-care, community care, primary health care, and the specialists right at the end. And I think it dovetails very nicely with what we are trying to do in Bukit Batok by creating awareness and hopefully getting our residents to be more aware about the strategies for self-care and how you can have access to community care and also to the primary healthcare providers. And some of them are also in the social, situated with the social service agencies. And it's been a very eventful year. I want to thank Albert, Linus, Fred, and everybody in the Green Ribbon Task Force for spearheading this initiative. Not only did they organize the webinars, but they also had posted to all Bukit Batok residents, and we have almost 50,000 residents in the constituency that I serve, a directory where they are equipped with the information on contacts, who to approach when they come across such cases, either for themselves, or family members, or neighbors, and friends, loved ones. So I think these are all very tangible things that has been done, and hopefully, we are now in a better position than we were in the beginning. I want to thank all the 10 partners who have participated in the mental health webinar talks. And they are the Singapore Tong Chai Medical Institution. They hosted a discussion on how Chinese medicine can complement and support our mental health. Now, this is important because, in Bukit Batok, there are a good number of our residents who subscribe to traditional Chinese medicine. In fact, the president of Singapore Tong Chai Medical Institution tells me that its West Clinic, which is located in Bukit Batok, is the busiest clinic in entire Singapore. They have about 5 clinics, and they see close to 200 patients a day. So it's a great opportunity to engage residents on this specific issue as to how mental health can be supported through Chinese medicine. And we also have Tzu Chi Foundation and Fei Active Aging Center. They have come in to share their experience in supporting mental health for seniors. And there, one of the therapeutic options is social connectivity. And I believe that this is something that Dr. Titajana spoke about just now as well. Certainly, the COVID-19 experience has thrown up this very clearly, not just in Singapore, but overseas as well. Loneliness certainly has a very major impact on one, particularly if you are a senior, having some issues, and it's going to be exacerbated. And the social connectivity. Fei Family Service Center, Singapore Anglican Community Services, Singapore Association for Mental Health. They have made very important contributions in the webinars on what can be done to enhance young adults' mental health. Okay, so it's extremely practical advice that's been given. So many thanks to them. The Caregivers Alliance, they did a fantastic job in providing some guidance to caregivers. And caregivers are usually the ones who are burdened, and at some point in time, they may themselves be subject of mental health issues. And I think this webinars by Caregivers Alliance was timely. Okay. And we certainly need to give our caregivers a scaffolding that's needed to be able to not just take care of their loved ones who may be suffering, but they themselves through a variety of measures, including peer support groups. St. Luke's Hospital was instrumental in spearheading our efforts to increase awareness of dementia, an increasingly prevalent problem in our community, in the month of September, which coincides with the World Alzheimer's Month as well. And of course, last but not least, we have Bukit Batok Polyclinic and Teng Fong General Hospital, which is anchoring our webinar series. And through the experts including Dr. Tajana, we now better understand common mental health conditions and where to seek help in our community, and what would be the strategies as well. So there's so much that's gained from these webinars, and to ensure that our residents and friends would have access to the wealth of wisdom and knowledge that's been shared. The Green Ribbon Task Force is going to upload the video recordings into their YouTube channel. Okay, now I'm not sure how popular YouTube channel is now compared to TikTok, because I think looks like everybody is going to TikTok. But anyway, I think YouTube is fine. If there's an opportunity to use TikTok, why not? I think, might as well use whatever platforms that's available, so long as, it's not too much of work. Okay, so this is something for all our Bukit Batok friends who are unable to watch the earlier sessions because they are, they're busy or other things to do. Okay, now I started my day on a very sober note, actually. At about 9:30 a.m., I was informed that there was a suicide case this morning. Usually, it's quite rare to have a suicide case in the morning. Usually, it's in the early morning. So somebody jumped down from a height. And whenever these things happen, it's a time for reflection for me. It's like, what could we have done as a community to prevent that person from committing suicide? I'm not sure whether the person is a fellow human being. It's clear to me that our work is not done. And we need to do a lot more on this front. What Dr. Linus Chua shared about discrimination at workplace is a real problem. When I attended a talk led by Caregivers Alliance, there was this lady who was suffering from a disorder, and her psychologist had given her a coping mechanism, which includes breathing exercise. And when one day she shared this with her superior and says, look, I have this problem, and when I'm into this situation of anxiety, I will have to take some time to breathe and try and remain calm. The superior said, you mean I have to wait until you finish your breathing exercise? I was stunned when I heard it. But these are the kind of challenges that people with mental health issues face daily. So we have to be realistic. And President Halimah has shone a torchlight on this issue. And hopefully, at the parliament level, when we are discussing the enabling master plan, we can give more teeth and support for people with mental health issues and their families, so that we can more effectively deal with issues of discrimination. At the end of the day, it's not enough to just say that we are an inclusive society. We have to mean what we say through action. This series is focused on raising awareness, highlighting avenues for help, signaling that no one is alone. We will rally around each and every person who faces such issues. And I do hope that, in this month of November, as we're heading to the festive season, we are actually feeling more hopeful, even though, as I said earlier, there continues to be pressing need for intervention at various levels. So I'm cautiously optimistic that we are headed in the right direction. And I do hope that we can enlist on everyone's support here to continue with this mission. And let me end off by expressing my deepest appreciation and thanks for all that you have done to help this very important group of people who are very much part of our society. And we need to do our part to make them feel included in our society. Thank you. Thank you very much.
Thank you, Advisor Murali, for sharing and closing off the series. We have come to the end of today's session, and we would like to say that this event would not have been possible without the support and the management of the management team from Teng Fong General Hospital, especially Ms. Chi Jia, who has been supporting and coordinating this talk. And a big thank you once again to Dr. Irene Tatayana, who's the head and senior consultant of the Department of Psychiatry at Teng Fong Hospital. Thank you very much for sharing your insights and for your time with us this afternoon. If you find this session useful and would like to share with your fellow neighbors at Bukit Batok, you will be able to find both the audio and video recording of the session on Bukit Batok and Advisors Facebook pages towards the end of this month. And once again, thank you, Advisor Murali, for your constant support throughout the whole year and through the prior years. And we look forward to continued support in the years ahead. Thank you very much and have a good afternoon ahead.